Afternoon. This is Peter Petros, and I'm calling in from Sydney, Australia. The topic of my lecture is how can the integral system help looming care incontinence problems? Global demographics. By 2050, 1 in 6 people in the world will be 65 years or more, and they're living longer. And of course, this puts increased financial pressure on old age support systems. An important statistic is that 50% of women over 80 years have nocturia, and nocturia has a high association with fractured hips. In fact, they call the two giants of aging, the two giant problems are fractures and incontinence. People aged 70 years or more than a quarter of them have incontinence, and of these, more than a third have fallen over in the previous year. The cost of hip fractures in Europe alone is $1 billion per annum, and the indirect costs of nocturia, total indirect costs, such as absent from work or whatever, drugs, everything, in America is $62 billion per annum. The cost of nocturia alone in America is $62 billion per annum. And China? Well, China's population is aging. The United Nations estimates that the number of people over 65 will be 330 million in China by 2050. Why? Well, Mao Zedong had after Mao Zedong, there was a one-child policy, and this created future distortions. That the dependency ratio for retirees in China could rise as high as 44% by 2050. That's a quite frightening statistic. So where are we with bladder treatments now? Well, let's take the International Continence Society. They're their guidelines. Now, the International Continence Society defines problems as coming from the bladder. For instance, the definition of overactive bladder suggests that the problem is in the detrusor. And the treatments are all directed to that. They've got anticholinergics, which cut down the detrusor contractions. Botox does the same. Underactive bladder has no treatment available whatsoever. In other words, patients with urinary retention are told, sorry, we can't help you. Stress incontinence, there's Kegel, which works well, but the surgery for stress incontinence, of course, is part of the integral theory. Fecal incontinence, the ICS says there's no cure. Integral theory says, yes, we can cure that. Obstructive defecation, ICS says no cure. Yes, integral theory can cure both of those by repairing the posterior ligaments, uterosacral. So what is the integral theory? Integral theory says the problems in the bladder or the bowel, the problem isn't actually in the detrusor muscle of the bladder or the bowel. The problem is in the control mechanisms, the muscles acting against the ligaments. So if the ligaments are loose, then you will get problems of bladder and bowel and pain. Why do the ligaments get loose? It's all to do with the collagen. The collagen is the structural component of the ligaments. So the integral theory is very simple. If you can strengthen the ligaments, either through exercises or through surgery by putting in a tape, or even by plicating them, if the ligament's good enough, the collagen ligament, then you will fix the symptoms. Let's repeat that. The treatment of the integral theory is, firstly, to strengthen the muscles and the ligaments by squatting exercises, or plicating the ligaments with native tissue repair in the younger woman, and in the older woman, you've got to put a tape in to create new collagen. Collagen is the main structural component of the body. I won't go through the chemistry of it, but if you look down here, the collagen is bound together, intramolecular and extramolecular bonds. In pregnancy, women get symptoms of bladder and bowel symptoms, urgency, nocturia. Why? Because the hormones break down the bonds and the collagen weakens, and they get the problems after the menopause. Because after the menopause, when the estrogen production stops by the ovaries, then the collagen in the ligaments breaks down and is excreted as hydroxyproline. But let's look and see what happens. Most of the time, now, if the baby's had good strong contractions around the uterus, the baby's head will flex, and the flexed head is only due to the ligaments and the muscles. That's elementary. The prevention, well, the main prevention is if you don't allow a long labour. So if the patient is having weak contractions, give us some Syntocin to strengthen the muscle contraction. That'll flex the head. It'll go from 11.2 to 9.4, and you'll get less damage coming down. Now, we demonstrated this in a recent publication with Dr. Beale. We found that women who had passive management of labour had 8% anal sphincter tears. This is primogravid women, 8%, 8 out of every 100. If you compare that with the National Women's Hospital in Dublin, their rate was only 2.6%. So the integral theory says basically, the main discovery was 3 muscles, forwards, backwards, downwards. These muscles contract against pubourethral ligament anteriorly, here, uterosacral posteriorly, and they close the urethra. There's the urethra, they close it. They open it, and they stretch the vagina to support the stretch receptors. N are the stretch receptors. So when the hydrostatic pressure of the urine comes down, if it's inconvenient to go to the toilet, these muscles stretch the vagina like a trampoline. They put pressure underneath, and it stops the afference. And that's how the body controls urgency. Dysfunction, of course, if you've got loose ligaments, pubourethral ligament is loose and the uterosacral is loose, a muscle needs a strong anchoring point for a good contraction. If the ligaments are loose, the muscles are weak, so that's how, so you can't close the urethra, you can't open it properly, you get obstructed micturition, and you can't stretch it to support the hydrostatic pressure of the urine, so you get afference coming up, activating the micturition reflex, and that is perceived as urgency. As we said, if these ligaments are loose, the muscles which contract against them are weakened, so the stretch receptors cannot be supported from below, because if these muscles are weak, they can't stretch the vagina to support the stretch receptors like a trampoline, so they get afferent, more afference, activate the micturition reflex, and this cortex perceives this as urgency. It's just like a normal person wanting to go to the toilet. What do you get? You get urge. Exactly the same as you get with overactive bladder. That's the same symptom. And that's what the integral theory says, that overactive bladder symptoms, urgency, nocturia, frequency, are a cortical perception of a micturition reflex that is not properly controlled. Treatment? Okay, young people, if you strengthen these muscles, they pull against the ligament, they're stronger muscles, stronger contraction, and you can make the ligament stronger. Kegel can't do this. Kegel strengthens the puborectalis muscle under here to lift everything up. So this is only with the 3 reflex muscles. Now, this is something which I hope that the people listening to this lecture will copy and use in their daily practice, because symptoms will tell you which ligaments are loose. So there are 3 ligament zones. You've got ligaments in the front, pubourethral. You've got ligaments in the back, uterosacral and perineal body, and ligaments in the middle, which is cardinal and arcus tendineus. So if The symptoms tell you which ligaments are damaged. If you've got stress incontinence here, you know it's the pubourethral. So you can do Kegel, you can do squatting, or you can put a sling. There are two symptoms which are very specific for the uterosacral. If you have a patient with nocturia or chronic pelvic pain, you know that the problem is in the uterosacral ligament. Now, you can strengthen these uterosacral ligaments with squatting in young women, but old women, you have to put a sling. Exactly the same as a mid-urethral sling. It's like TVT in reverse. You put the sling posteriorly. So squatting automatically strengthens the three muscles and the ligaments. Now, in younger people, they've done experiments on this. Exercises are collagenopoietic. In other words, exercises create new collagen in young people, especially in young children. For instance, we've just had a paper published to show an 86% cure rate in daytime, nighttime enuresis, bedwetting, by doing 10 to 15 squats every morning and every night for 4 months. They've got to be done diligently and recorded, and you can get a very high cure rate for bedwetting. They're growing. They create bones. They create ligaments. They create tissue. That's all collagen. They're in collagen creative mode. So they create new collagen in the ligaments and the muscles. What happens at the menopause? In the menopause, the ovaries stop working, so there's no estrogen to keep the collagen in good condition in the ligaments. So the collagen breaks down. It breaks down in the bones to cause osteoporosis. It breaks down in the ligaments to cause urgency, nocturia, obstructive micturition, obstructive defecation, because they can't empty and they can't close. This is from Patricia Skilling's squatting exercises in premenopausal women. Now, this isn't cure. These conditions had 50% improvement. So you can see the number here, the condition. Now, 82% were 50% improved. Now, these are different from Kegel. Kegel, you've got to, when you're coughing, you've got to lift your pelvis up. With these squatting exercises, you don't have to do anything. It's just like going back to normal. So 82% improved, half improved, 68 for urge, 83 for frequency, 90% for nocturia, and 76% for chronic pelvic pain. So this improves the strength of the ligament. I'll go through this briefly. Native tissue repair. Of course, during childbirth, you can see here that there's a dislocation of the fascia attachment to the cervix and also the cardinal ligaments. So we do a transverse incision, suture the ligaments that have gone down here, we suture them back up here, and suture the vagina up here. That's what we call a transverse defect, and usually there's a cystocele. Hysterectomy, different, with a hysterectomy or uterine prolapse, we do a transverse incision 4 to 5 centimeters below the cervix and just stitch the ligaments together. Now, Professor Shkarupa from St. Petersburg in Russia did a very interesting comparison of cardinal and uterosacral ligament repair in pre- and postmenopausal women. If you look down here, he monitored prolapse, pelvic organ prolapse, nocturia, urgency, frequency in premenopausal and postmenopausal. Now let's just look at nocturia at 3 months. Premenopausal, very good results by cardinal and uterosacral ligament repair that I've just shown you. Not too bad in 3 months for postmenopausal. At 6 months, there's a rapid deterioration in the postmenopausal. Not much difference premenopausal. 12 months, catastrophic. Look at this. 25% for nocturia. But let's look at 18 months. In premenopausal, so almost 80% cure for prolapse, 15% for postmenopausal. That's plicating the ligaments, okay? Nocturia, pretty good, 87, 20%. Urgency, 67, 17%. Frequency, 59, 15.4. So in other words, if you haven't got any collagen in the ligaments, you're not going to get a good result by stitching them together. Now, interesting question. Karupa asked a very interesting question. What happens when these patients reach the menopause? The results like this. But premenopausal, you will get very good results for overactive bladder and prolapse just by ligament repair. Cardinal, you've got to do both, cardinal and uterosacral. Now, this is some experimental work. This is the work that led to the midurethral sling. I started it in 1986 at Royal Perth Hospital in experimental animals, dogs. And we took the tape out at 6 weeks. And you can see here that the collagen, that the tape created new collagen to form neoligaments. And of course, this is the basis of the midurethral sling, except we leave the tape in. We don't take it out. Now, this is some work by Professor Liedl, and it was a 616 patients, where 70-year-old women, they did a cardinal and uterosacral ligament repair. Now, at 12 months, these were the results. Now, you saw the results which from St. Petersburg at 12 months, pelvic pain, well, they didn't do pelvic pain, but nocturia was 15%, here 68. Prolapse, here they got 90% cure rate. Some postmenopausal in St. Petersburg was 15. And here they cured fecal incontinence, urge incontinence, 85% at 12 months. Nocturia, 68, was only 15% at St. Petersburg. So these are very good results. Now, they're very expensive too. They use 2 tapes, $1,000 each. So, but we're developing now what we call an artisan tape, where we do the plication of the ligaments. As you saw, the results at 3 months are good. And we just put a tape across, an artisan tape. That creates new collagen. And the results at 3 years with my PhD student in Venezuela are very, very good indeed. So that's emerging technology for, especially, we developed it especially for countries which are not wealthy, like Venezuela and some of the Latin American countries. But of course, it can be done anywhere. It can be done in America, in Australia, in England, and of course, China. And the results at 12 months or 3 years, not quite as good as this, but maybe 15% less good, still good. We're developing some probes to mechanically support damaged ligaments like the uterosacral. Again, this is work which is still being done. Now, what has the ICS system got for OAB? As we said, midurethral sling, that's integral theory. So Kegel, that work okay. What do I look for OAB? Not very much. This is the cost of anticholinergic drugs for 6 months. Over $1,000. Botox, not much difference. OAB. Now they're putting in wires into the spine, sacral nerve stimulation. It's pretty expensive. And you don't get cure. Like, if you get 50% improvement, that's said to be a good result. And this is what it costs for 50% improvement. Up to $44,000 in Boston and a bit cheaper in Florida. Chronic pelvic pain, nothing. Fecal incontinence, nothing. You can get very good results with these in older women if you do a plication and you put a tape in. How about the integral system? Well, the treatment options based on the integral theorem are all inexpensive. But if it's non-surgical, you get poor ligament collage, you get poor results. Even surgical, you get, if you sew it up without a tape, you get poor results. But let's look at younger people. Have a look at this. Squatting base pelvic floor, native tissue. These are, you get good results for these, as I've shown you, in premenopausal women. squatting-based pelvic floor native tissue ligament repair do not work well in older women. So the options for older women are pessaries, okay, or tension-free tapes added to ligament repair to create new collagen. So let's summarize. Older women have a big problem. The problem is they haven't got enough collagen. So the only way to create new collagen is the method that Professor Papadimitriou and I and we showed conclusively in the experimental animals that firstly, it was safe with radioactive gallium studies and so on. And secondly, we showed that you can get a ligament, a collagenous ligament, to reinforce the weak collagen in the old women. Now, some Japanese colleagues using the TFS, they've got 5-year data, and there was a drop in prolapse repair cure from 90% to 79% at 5 years. That's fantastic. So with old women, if we can put the tape in, you will get long-term cure. Okay, that's the takeaway message. Thank you very much.
Okay, great.
How long was it?